Awesome. Thank you so much, Hazel. Good afternoon, everybody. Thank you so much for joining our webinar today. We're going to jump right in. As folks are very, very well aware, we are facing an affordability crisis around in the U.S. healthcare system. In a 2022 Gallup and West Health poll, 75%, 3/4 of the American people gave the U.S. healthcare system around affordability a grade or a D or an F. A third gave it an outright F. We know that nearly half of folks don't see a doctor when they need to because of the costs. 30% say that the cost of medical care is interfering with their basic needs like food and housing. And the list goes on. And we are really in a moment when the public concern over affordability is continuing to mount and continuing to grow year after year. Next slide, please. Some of these slides might look a little familiar to folks, so I'm going to move sort of quickly just as sort of foundation. The affordability crisis that we're feeling as individual consumers and people of healthcare is playing out at all levels. It's playing out at the federal level, which is what this graph shows us, that we are now spending nearly 20% of our GDP on healthcare. And you can see here in 2040 that healthcare spending is projected to surpass all other budget lines, including other non-interest spending for the first time. It's already surpassed Social Security spending, net interest. If you can go to the next slide, we are seeing a similar issue around spending at the state level playing out, where Medicaid spending is outpacing growth in state tax revenue. And in 2028, CMS is projecting that the Medicaid program nationally will exceed $1 trillion in spending for the first time ever. And what this looks like on the next slide, please, what this looks like for people, as you are all very well familiar, that premium increases continue to outpace the growth in overall inflation and workers' earnings. And so we are really feeling the pressure at all levels in terms of the impacts of rising healthcare costs and affordability on our ability to secure other things in our lives that we need in terms of our budgets. If you can move to the next slide. And as you all know, for all of the spending that we're putting on healthcare, the United States has some of the worst health outcomes. We have much higher rates of treatable and preventable death, which is what you see here and predicted in this graph, which are two really important measures of the efficiency and effectiveness of a healthcare system to intervene and keep people alive and get them the treatment they needed. We have much higher rates of those deaths compared to other developed countries and countries that are in similar economic standing as we are. And if you can go to the next slide, the data are very, very clear that good health and healthcare are not equally available to all in our nation, particularly for racial and ethnic minorities. We see much higher rates of disease. For example, cardiovascular disease is the leading cause of death across the country. For non-Hispanic Black adults, they're seeing at least a 50%, they're 50% more likely to die of heart disease and stroke prematurely than their non-Hispanic White counterparts. Incredibly high rates of infant mortality rates, and just example after example of how people of color in particular are falling through the cracks of the system, and we are not meeting the health needs of all in our country by any measure. If you can move to the next slide. Really simply put, our healthcare system has lost its way, and we really see two primary financial drivers of unaffordable, inequitable, and low quality care in the United States. The first is around high healthcare prices that's driven by healthcare corporations and medical monopolies buying up local competition to price gouge. And the second really is around fee-for-service economics as the predominant payment model in the US healthcare system. If you joined us a couple weeks ago for our last webinar, we spent much of that session focused on the first part of this around high healthcare prices driven from medical monopolies. But today we're going to do a deep dive into fee-for-service economics and much of the waste and fragmented care that's being driven by the predominant payment model in the US healthcare system. If you can move to the next slide. So with that, Adam, I'm going to turn it over to you to take us through the next couple slides.
Thanks, Sophia. And Sophia really did a great job of just talking about the challenges that we face in this country with healthcare affordability and the cost of healthcare. And I want to talk a little bit about how the way that we pay for healthcare, and in particular, the economic incentives of fee-for-service are driving some of that unaffordability. Quite simply put, you get what you pay for. And in a fee-for-service system where you're getting paid for the things that you do directly, it's working against the desire responsibilities of healthcare providers to improve health and reduce disparities, and instead is encouraging them to do more expensive services, high margin services, rather than trying to take on improving health, reducing disparities. When you have a system that pays you for how much you do, your incentive is to do more things. And we have seen really clearly that the business model for large healthcare corporations is to buy up providers that have high volume and a particular high volume of high margin services, and then use that market power to drive up the price for the services they're providing as much as they can. And I think physicians know this. There was a survey of physicians that found that 25% of tests and 11% of procedures were medically unnecessary, and that 70% of physicians thought that doctors were more likely to perform unnecessary procedures when it was profitable for them to do so. So on the one hand, you're getting what you pay for. You pay for doing more things, you get doing more things and not better quality of care. But you're also not getting what you don't pay for. And so fee-for-service payment is really focused on reimbursing clinical care and not addressing social determinants of health, which we know are so crucial to helping people achieve their best health. Fee-for-service doesn't pay for reimburse or incentivize efforts to address the underlying causes of health, and therefore we're not getting as much of that. We're getting more services with high margins. When your reimbursement is predominantly tied to how much you do, how many patients you see, you're discouraged from taking on patients with higher risk, greater needs, and whether that's due to medical complexity or because they're historically underserved populations. So next slide, please. So let's say that we accept that fee-for-service is at the root of the healthcare cost crisis that we have. We've seen that there have been a lot of efforts over the past 15, 20 years to address fee-for-service economics and its impact on our healthcare system. But unfortunately, those efforts have really largely failed to move us away from those fundamental aspects of the way that we pay for healthcare. It just hasn't lived up to its promise. We see that the healthcare industry is double dealing. On the one hand, they're driving up prices through consolidation. We're going to talk about that a little more and have talked about that in many of these webinars. And on the other hand, they're touting these efforts to implement value-based payment. But what we're really seeing is that very little of the reforms that have taken place to date are moving away from fee-for-service economics. Less than 8% of healthcare services are paid for in this country right now through a method other than fee-for-service. And it's true across all different payers. Fee-for-service is the predominant payment model in Medicare, Medicare Advantage, Medicaid managed care, private insurance, across the board. Next slide, please. And it goes beyond that. I talked about this a little bit before, but healthcare monopoly, healthcare corporations and medical monopolies have used the promise of payment reform to justify increasing vertical and horizontal consolidation, which is just leading to less competition, lower quality of care, and higher costs. And so we have a couple examples up there and talk about them in our paper, where large healthcare corporations have used the promise of payment reform and value-based care as a justification to further consolidate their market power and drive up prices further. UPMC is a really great example of that. It's a dominant healthcare system that has used efforts to try and support payment reform as a justification for its really strong consolidation. But what we've seen is that from their financial records from 2022, they haven't really taken meaningful steps away from the fee-for-service payment model, and they're have record high margins on based on commercial prices, largely due to the consolidation that they've been able to accomplish. Mass General Brigham is another great example where They, in their 2019 rebranding, talked about the focus on value-based care, and yet 3 years later received, I believe, the first performance improvement plan from the Massachusetts Health Policy Commission because of their outsized contribution to the unsustainable cost growth in the state. Another example of these payment reforms where we have seen a failure to move away from fee-for-service economics is in pay-for-performance. Ultimately, these are still based on fee-for-service payments, and the data have been really weak on their ability to improve quality or lower cost. And frankly, they disincentivize providers from investments in socioeconomically disadvantaged populations. If you have patients that are harder to care for, if you have patients that have greater needs, you jeopardize your performance on a pay-for-performance basis. And again, it's an example where something that has been touted as payment reform hasn't really benefited patients. So with that, I'm going to hand it back to Sophia to talk a little bit more about the sort of promise of real payment reform and what we can do to make sure that payment reform efforts are working for patients.
Thank you very much, Adam. And on that pay for performance piece, I think the other point to just lift up is that most claims of value-based payment are actually just pay for performance. And Adam did a really nice job of laying out why that's not a really meaningful movement away from fee-for-service economics and the mixed results we continue to see in those types of models. But so many claims of moving towards value are just still anchored in fee-for-service with some incentive payments layered on top. And we would make the case that that's actually not moving towards a model that's going to meet people's needs and lower healthcare costs. So our point here is what we wanted to talk about is around if we do payment reform right, it actually can serve as a critical tool to help to refocus the healthcare sector so they can do the things that we know that need to get done in the healthcare system, like addressing longstanding disparities, improving people's health outcomes. To do this, we really have to make a fundamental shift away from fee-for-service economics and establish a business model that's actually viable for the healthcare sector that does a few things. The first is that we have to create new financial incentives that are going to pay providers for actually keeping people healthy. We're going to pay providers to actually reduce disparities. And through that, we're going to ensure that there is affordability for the system, but also for people without relying on price gouging. What this means is that we have to make it in the best, economically, we have to make it in the best interest of providers to actually address whole person health needs. And what that looks like is an economic model, a business model that is actually holding providers accountable for health outcomes and the total cost of care for patients. And it includes making sure that there are really strong outcome measures, accountability through outcome measures, including disparity reduction measures, and driving towards improved quality. And one of the great models we'll talk about in a second that is sort of the North Star on this is around moving towards a population-based payment model as an alternative to fee-for-service. But really importantly, before we talk a little bit more about population-based payment, I want to make an important note here to say what we are not talking about in payment reform. And that really is about, we are not saying, we are not threatening Medicare or Medicaid. We are not threatening the entitlement at all, or aspects of the program that we know work for people. This is about making sure that we are actually protecting the entitlement and Medicare and Medicaid to be around forever to serve all the people who rely on those programs for health insurance coverage. So that's a really important distinction that we're happy to talk about more later. If we go to the next slide. So if we're not doing fee-for-service, what are we doing? And we would posit population-based payment models as an alternative. And this really looks like a payment to providers. Typically, it's a primary care organization or a health system of some kind that's receiving a single, we would argue, an upfront prospective monthly payment, out of which the organization is then able to pay for some or most of its healthcare costs for an entire population. So in this way, providers are actually become what we call at risk for care that's wasteful and that fails to improve patients' health. So what that means is a provider is going to generate revenue when they are efficient and improve health, reduce disparities, protect patient health, and they actually can lose money if they don't do those things and are providing really wasteful care or really low quality care. And really importantly is that part of this the population-based payment model is that we have really strong quality and outcome metrics that are going to ensure that the provider's economics change, that the way that they sustain themselves in their business model flip, so that they can generate revenue by keeping people healthy, meeting people's health needs, and not just price gouging, or that might be applicable to health systems, or generating high cost, high margin procedures that are not actually meeting the specific needs of people's health. And when we do this, when we restructure payments in this way, we actually incentivize all the things in the healthcare system that we know we need to do to actually drive people's health. That's really important comprehensive care coordination. That's making sure that care is patient-centered. It's making sure that we can actually provide payment to providers for delivering services that are going to address the social determinants of health, and all of the health-related services that we know drive 80–90% of people's health that Adam talked about earlier, that we are actually creating those payment incentives through this population-based payment model, in addition to making sure that we've got payment for standard medical services and procedures. If we could flip to the next slide, please. So I'm going to turn it back over to Adam, because a lot of this is theoretical. I'm sure a lot of this is familiar to folks, but we wanted to do to lift up some really, and there are a lot of examples, but we wanted to lift up a few really key examples of what we think is authentic healthcare transformation that are making really important strides towards population-based payments, strong accountability around total cost of care, and improving health outcomes, reducing disparities, and some key elements that are important to take note of. So Adam, I'll turn it back to you.
Yeah, and making sure that payment reform is working for patients, which I think also often we're hearing about payment reform from the perspective of providers, but what's ultimately matters is at the end of the day that these efforts are working and benefiting patients. And so I'm going to talk about some examples that we talk about in our paper from a couple different areas. One, largely from the Medicare space, is Oak Street Health, which has been in the news quite a bit, but for good reason. And they're doing really interesting and important things. This is an accountable care organization. They participate in the Medicare Shared Savings Program, ACO REACH, and also partners with Medicare Advantage plans. But they have a really strong focus on both primary care and in particular on medically underserved communities. So 90% of their clinics are in medically underserved communities, and more than half of their patient population are minority populations. So they're really taking on both addressing access to primary care and addressing health disparities, which is incredibly important for these payment reform efforts. Another way in which they're focusing on primary care prevention and disease management, just one example, their patients see their primary care providers about 8 times per year on average, as compared to about 3 times, which is the average nationally in Medicare. So they're getting patients in the door, they're taking care of their healthcare needs, and they're seeing pretty significant cost savings to the taxpayer by improving quality. And so we have some numbers here which are pretty stark. They saw a greater than 50% reduction in inpatient hospital admissions, more than a 40% reduction in 30-day readmission rates, and a more than 50% reduction in emergency department visits for their patient population. That's huge, right? That's a huge improvement in quality of care. And they were able to show a really significant savings from that as well. They were, one of their ACOs was I think the 4th highest savings rate in the ACO program, saving about $1,200 annually per beneficiary in savings to the taxpayer. Another example we want to hold up is around behavioral health integration, and in particular Vermont's all-payer ACO model. This is a model that's done in partnership with the Center for Medicare and Medicaid Innovation, as well as the state and state insurers. And it focuses on patient-centered medical homes with community health teams. These are community health teams that are made up of nurses, mental health clinicians, community health workers, and dietitians, and really proactively trying to meet the needs of their patients, including screening for social determinants of health, and have seen increased access to care from this model. So similarly, this model has seen a 6.8% reduction in Medicare spending, again, driven by improvement improvements in the quality of care. So this was in the second year of the model. They saw a 6.8% reduction in spending, a 17% or almost 18% reduction in acute hospital stays, and about 12.4% reduction in 30-day readmissions. That's varied over the course of the model, but has been pretty consistent that they've shown both improved quality and reductions in Medicare spending. Next slide, please. So another example of authentic healthcare transformation is around the concept of bundled payments. And so one example that we pulled out here is bundled payments for maternity care at Geisinger Health System in Pennsylvania. They took on risk for all prenatal, labor and delivery, and postpartum care. They implemented a number of really robust quality metrics that they applied across all of their providers, and were able to see really significant increases in rates of prenatal screening and reductions in C-section rates and the use of the neonatal intensive care unit. And I think another thing that's important to note here, part of the goal of payment reform can be improving quality. And you know, oftentimes we talk about payment reform in the context of reducing costs. That's part of what we're trying to do, is rein in this expansive cost growth. But if we can improve quality while maintaining similar costs, that's also can be a success story in the way that we're approaching these issues. And then the last example that we wanted to talk about was coordinated care within Medicaid, in particular Oregon's coordinated care organization. So Oregon has 15 coordinated care organizations that provide integrated medical, behavioral, and health care services to their Medicaid beneficiaries. These CCOs have a global budget that covers physical, behavioral, and oral health services. And the CCOs are responsible for coordinating, integrating whole person care for those patients. It's been a successful program for a long time, and in 2019, the program was revised to encourage CCOs to make investments with some of the savings that they were seeing in efforts to address health equity and social determinants of health. And there's actually, the program was also revised to provide some funding specific to those CCOs that were successful at addressing health equity measures. So yet another example of ways in which you can sort of use the savings from payment reform to reinvest in the healthcare that patients are receiving and the services that people are receiving outside of traditional healthcare as well. And the Oregon example has been one where we've seen, again, increased quality of care combined with fiscal sustainability. So there's a 10% decline in emergency department visits, a 17% decline in non-traumatic dental conditions, and during that time period, held Medicaid spending growth about 2% below the national average. So these are just a couple of examples of ways in which payment reform, when done well, can benefit patients, can increase quality of care, while also helping to rein in our healthcare cost challenges that we face as a country. Next slide, please. So, I mentioned this earlier, but I wanted to hit on it again, that I think too often conversations around payment reform are dominated by providers, because at the end of the day, it's determining what they're getting paid. But I think we here at Families USA are trying to encourage folks that are speaking on behalf of patients and consumers to get involved in this conversation. If we're not there, no one is speaking on behalf of patients, and we're not going to see the outcomes that we want to see. So a couple of examples of ways that folks on this call or on this webinar can stay involved. One, joining comment letters on upcoming annual payment regulations, in particular the Medicare Physician Fee Schedule, which contains rules around the Medicare Shared Savings Program. Another is to sort of stay involved in Families USA's efforts as we continue to work on them, to engage in consumer and partner roundtable on policy solutions and next steps around payment reform, and how we can make sure that payment reform is working for patients and consumers. And for more information about those efforts, please reach out to Mike Persley. He's been sending you a bunch of the information about this webinar, and his email address is right there on the slide. And then also, I just wanted to use this as an opportunity to tout our newsletter from the Families USA's Center for Affordable Whole Person Care. It comes out, I believe, bi-monthly, and has lots of really great content, and can help keep you up to date about some of the opportunities to continue to be involved. And again, for that, if you can contact Mike with his email address there, that'd be great. And then I'll pass it back to Sophia to talk a little bit about some of the resources that Families USA has put out on these issues.
Thanks, Adam. And I want to just go ahead and say that this, I'll quickly touch through some of these resources, but we're moving to the Q&A section of the webinar. So if folks have questions, please go ahead and drop them in the chat. Happy to answer anything that might be on your minds around the content you've seen today or other things that you might be thinking about in terms of payment reform. We'll do our best to field your hardest questions. So please go ahead and drop those in the chat if you have any. Just pointing to you guys to some resources. We've been putting out sort of a series of publications. Hopefully you've seen some of them, but really are telling the story around the ways that the healthcare system has lost its way, both in terms of affordability, but in terms of meeting people's health outcomes and reducing disparities. In particular, much of the content which we talked about today is the sort of fifth paper here. But I do want to make sure that folks have seen this Do the Right Thing, Shifting Healthcare Payment to Value-Based Incentives to Achieve Health Equity and Promote Racial Justice, authored by our Senior Director of Health Equity at Families USA, Stacey Lofton. It's an excellent resource and offers, I think, a really fresh and innovative way to be thinking about payment reform and the failures of fee-for-service and exacerbating disparities, and really protecting the status quo entrenched economics that historically and systemically have left people of color behind in our country, and the ways that we can actually start to chip away at that through reforming the economics of our healthcare system. So really want to make sure folks have had a chance to see that. A comment letter that, sort of our comment letter from last year on the Medicare physician fee schedule, which gives you a sense of some of the ways that we've been interacting with CMS around the Medicare Shared Savings Program. And then if folks are interested, we do have a policy agenda that sort of wraps up much of what we've talked about today, as well as much of our hospital pricing work, which many of you have been in the loop on over the last year or so, and a policy agenda that you can check out in our Center for Affordable Whole Person Care. That really sort of wraps up our formal content of what we wanted to run through with you all today, and happy to turn to any questions that folks might have. While folks might be thinking of questions, one thing I wanted to just lift up that around the Oregon CCO model that I think is so innovative is around their how they're using their administrative funds, which Adam mentioned is coming out of their new sort of Oregon CCO 2.0 model that launched in 2019. But the way that they're structuring these benefits actually allows them to take dollars and spend it on healthcare services that fall outside of traditional medical services. So they actually can pay for things like food service and supports. They have vouchers for meal delivery. They can address housing supports and services, including utility assistance and environmental remediations. There's a whole package of health-related social needs services that this reformed structure with some really important guardrails, and obviously Oregon has learned quite a bit over the years that they've been operating this model, that they're now able to do that is very innovative and interesting. There are of course other examples of this happening around the country too, but an important point to pull up, particularly as we're seeing from the financials of the CCOs since 2021 that these models are actually sustainable, and their operating margins are increasing, which is really important.
Yeah, and I just want to hit on that last point, Sophia, that if the models aren't sustainable, then they're not going to work for patients, right? Like that is a piece of making sure that payment reform works for patients, is that models are able to be sustainable. And so I think that's something we tried to highlight in the paper and in the webinar as well.
It looks like you guys, we're trying to make a fix. It looks like we've got a little problem with the chat. We'll see if we can get it fixed. Hopefully there's an ability for you to drop questions into the Q&A part at the bottom of your screen. A couple of questions coming in. A question around if there's any consideration for bonuses to healthcare providers and patients who achieve certain set goals in terms of control of blood sugar, blood pressure. I think absolutely. I think that's where we want to drive towards, that we're actually tying payments to measures of improved health outcomes. So effective measurement of blood blood sugar, right? And effective management of blood pressure, for example, for certain diseases and conditions. So I don't think we're there yet. But I think that's absolutely the direction that we want to push, that it's not just holding providers accountable for process measures and quality measures, but ultimately we want them accountable for health outcomes, like the actual improved health status of the people that they're serving in their patient populations. Another question coming in, major criticism of value-based payment is administrative burden. Exactly what we don't need more of for those who are clinicians. Yeah, a great point. There is, of course, administrative burden, which is particularly problematic for providers who don't have a lot of cash left over at the end of a month or the end of a year, and are really on a thin operating margin budget. For example, primary care docs, right? It's super, super challenging for them to make the upfront capital investments into the types of systems, data systems that they need, medical record systems, putting their whole practice or onto, into a sort of a data tech modern interoperable system. And it's a major barrier for a lot of providers to enter. So I think we absolutely have to solve that, address the administrative burden, and particularly for certain types of providers, safety net providers, primary care docs, there's others, the types of investments that they need to be able to participate effectively in these models so they can continue to serve the most vulnerable people in our country.
And I would say too, right, that fee-for-service, systems, payment systems have administrative burden too. It's expensive to the sort of billing associated with getting paid solely based on the individual services you're providing, and the sort of gaming that allows helps to build administrative burden on the other side too. So I think when you're talking about transitioning and using per beneficiary per month payments and that sort of model is one way that you can, in some cases, try and reduce some administrative burden in that way. And then another question that came in from Larry McNeely around the importance of including patients and consumers in governance of not just health centers, but also community health institutions and ACOs. I think that's a really good point. And I think there are lots of different ways to ensure that payment reform is working for patients. One way to do that is to ensure that patients are included in, and patient representatives and people speaking on behalf of patients are included in the governance of accountable care organizations and other organizations that are serving to help manage some of these efforts to move away from fee-for-service. So I think that's a great point. I think that's part of it has to be the way that we design these systems, but it's also partially including patients in governance too.
Yeah, and Adam, to just put a really explicit example on that, in the ACO, CMS's ACO REACH program, they've made really important, based off of a lot of feedback they got from consumer and patient advocates and others, like many of you on the call today, made some really important changes to the governance structure of the ACO REACH entities, which now have really specific requirements around an actual beneficiary being served by that model on the governance structure, as well as a consumer rep on the governance structure. So 2 positions on their that are now required to be an ACO REACH entity in the governing structure. It's a really, really important question. I love this question coming in from Mark about, these are super lofty ideas, but how do we actually, what's the step? Like, how do we get from here to there? And particularly around counteracting industry trends that are pushing things up in the opposite way around, like maximizing profit, prioritizing profit, price gouging. It's such an important question, Mark. I think it's a couple things. On the one hand, we got to go right after the abuses, as I know you are doing already through all of your incredible work, and continue to unveil the abuses that are happening in the system for policymakers. So many, particularly at the national level, and particularly in the new Congress, a lot of new members coming in. They're not tracking on payment reform. We're getting a little bit of traction, as you guys hopefully can see, around some of the other pricing abuses driven by the hospital sector. From obviously, there's a lot of stuff going on prescription drug pricing. We have to keep hitting the drumbeat and keep educating policymakers, help them understand what the impact of these policies are on consumers, on people. So much of the conversation, as you know, is dominated by industry. And we have policymakers literally telling us, like, show up and, we need you guys at the table on these issues, including payment reform, and helping to understand what's working, what are the faux reforms, where are they just exaggerating and misleading claims to price gouge, and holding up examples like some of the ones we went through today at Oak Street and others that are actually making meaningful changes to meet patients' needs. So I think, those are all sort of some pieces that we can keep plugging at. And I would say big picture, ultimately, we have to make it really uncomfortable for the current business model to stay, like the status quo, price gouging, consolidation, price gouging, and fee for service payment. We have to make both pieces of that really, really uncomfortable for providers, and we have to offer an alternative. So that's sort of like a big picture. There's a lot underneath there, but hopefully that gives a little snippet of sort of how we're thinking about it. All right, Eric, now the questions are flowing, guys. I love it. Let's see. Adam,
Eric,
I'll turn it to you.
I think Eric asked a good question, and Murray did as well in the chat about how do you involve patients in these efforts, and can thinking about the way we pay for healthcare affect the way that we're able to involve patients in their own healthcare decisions and facilitate or encourage patients to be involved in their own healthcare. And I think something that Eric got at is that again, and I said this earlier, right? Like if you're getting paid by how many things you're doing instead of managing the health of your patients, then you have an incentive to see as many patients as you can in a day. And so absolutely rethinking the way that we pay for healthcare, transitioning away from a fee-for-service model to things like this, population-based models that Sophia talked about earlier, absolutely are a way to facilitate providers to try and really dedicate more time to doing what they want to be doing, which is taking care of their patients. And then Murray's questions, I think, a little bit different, was around how can you sort of maybe have accountability for patients in this process. And I think it's a challenge for sure for in healthcare all of the time. But I think again, it's only made more difficult when you've got 10 minutes to see a patient and then you need to go see another patient. And when you're not able to use funds to invest in the sort of community health teams, in community health workers, in other ways to reach patients, then it's that much harder to reach people and bring about behavior change to the extent that that's impacting the health outcomes for patients. So it is another way in which I think addressing the challenges and the broken economics of fee-for-service can help to improve the care that we're all getting.
Yeah, and I'll just add on that. I think part of, it is essential that people and patients and their caregivers and their family members are brought into the care planning where it makes sense, and where they want to be involved. And these redesigned models, when we actually are allowing dollars to flow and incentivizing comprehensive care teams, and that we're thinking about caregivers and family members as part of the care team, that we're wrapping around an individual so that we can make sure that they get all the services they need, like that's the end goal, right? Like that is the goal that the system is flowing all about, from sort of the all the way throughout the design and implementation of these new models of care, that patients, people and their needs are at the center, and making sure that we're creating all the incentives around it that allow the actors in the system, the payers, the providers, to line up, have alignment and with common agreement about what that looks like, so that we can really actually make sure we meet people's needs. If we do that, to answer this question, like I do think it allows the time to do that, right? Like we do take away sort of this idea that we're paying providers based on widgets, right? Like individual encounters. We know that that's not working for people. So many people falling through the cracks. So we do need a different way to do it. And my pitch to you guys is, we need a movement. We need a movement with consumers and people at the front of it, who are telling the story and helping to understand what this should look like for people. And so that's part of what we hope to engage with you all on in the months ahead. Other questions for folks? I'm just looking at the chat to see what, if any, we've missed. All right, if there's any burning other question, please do drop. Really appreciate, please do drop it in the Q&A. Otherwise, we'll wrap up. Thank you all so much for joining. Please stay tuned to stay in the loop. Make sure you're getting our newsletter. Reach out to Mike personally, his email's there. You can reach out to myself or Adam at any point. And we'll be planning to do more of these webinars on upcoming topics. So please stay tuned. Appreciate everybody joining today, and hope everybody has a really lovely rest of the week.